Great. So thank you so much for everyone for being here. What a great conference. And we're going to finish it with the Disruptive Dozen, which is the most exciting, energizing, and the fun session of today. So I just want to mention how the Disruptive Dozen were selected from Mass General Brigham. So these are innovators and faculty members who have technologies that are going to have a huge impact by the end of 2024, and they were selected by a rigorous process with faculty members, senior Harvard Medical School faculty members from HMS. We're going to start from number 12 and work our way down to number 1. We will have each faculty present, each faculty has a video that will talk about their technology, and then we will have a Q&A session after that. So we will start with Dr. Paul Anderson, who will introduce one of the technology and the speaker.
Everybody, and welcome to our distinguished panel. My name is Paul Anderson. I'm the Interim Chief Economic Officer at Mass General Brigham, and happy to preside over the first 4 of these amazing presentations. Our first presentation is from our panelist, Rachel Wooten, Assistant in Pediatrics and Instructor in Pediatrics at Harvard Medical School, and she's also at Mass General Hospital. And her program is entitled Slowing the Progression of Type 1 Diabetes.
Number 12, slowing the progression of type 1 diabetes.
A new drug approved earlier this year can delay the onset of type 1 diabetes in children and young adults at high risk for the disease. Type 1 diabetes is a chronic illness that results when the body's own immune system attacks the insulin-producing cells in the pancreas, destroying the cells and creating a lifelong dependence on exogenous insulin. It is among the most common diseases to affect children, second only to asthma, and affects over 1 million people in the U.S. The newly approved drug consists of an antibody that targets a critical protein on T cells, deactivating them and thwarting their destruction of insulin-producing cells. Researchers conducted a randomized, controlled clinical trial involving nearly 80 patients with a genetic predisposition to type 1 diabetes. The majority of patients enrolled were 18 years old or younger. In those receiving the experimental treatment, the median time to clinical diagnosis of type 1 diabetes was delayed about 2 years. Although insulin replacement is an effective treatment for type 1 diabetes, it is not a cure. Despite improvements in care and technology, properly managing the disease remains a challenge that patients face over their lifetime. Moreover, studies suggest that children who are diagnosed with type 1 diabetes before the age of 10 can lose more than 14 years of life expectancy, underscoring the power of novel therapies that can delay or even halt the onset of the disease.
Dr. Wooten, how is this new therapy going to change the lives of your patients, and how will it change the way that doctors approach this devastating disease?
Well, I wanted to first thank you for the opportunity to talk about type 1 diabetes, and I wanted to dive into what treating this disease looks like for many of my patients. So while insulin is an effective treatment, it involves very frequent monitoring of blood sugars, very complicated calculations in terms of deciding the correct doses, and all of those calculations are changed by sleep, exercise, and what a child eats. So if we can even delay that by a few years, that can be so meaningful for our patients. I wanted to next just look at kind of what it looks like to be diagnosed with type 1 diabetes for so many of our patients. It's often happening in an urgent setting, in an emergency room, in an ICU, and these families are learning such complicated treatments in the most stressful situations in their life. So if we can even prolong that into something where they're able to really kind of learn it in a more controlled setting, a delay in diagnosis can be so powerful. And I also wanted to highlight just what I hear from my patients. We have a very small minority of patients that do have a delay in needing higher doses of insulin. And what I've heard from those patients is really the opportunity to learn the treatment before they really are living it, how meaningful that can be. So I think in summary, really just highlighting what that, even a small delay in diagnosis, just how powerful that can be for my patients. And lastly, thinking about it from a clinical standpoint, so I think this is really going to shift our mindset in terms of how we think about screening and prevention. So previously, screening wasn't something we really had a reason to do because we didn't have any effective treatments to really offer for it. But I was seeing a patient in clinic a few weeks ago that had a slightly high hemoglobin A1C with a family history of diabetes. And for the very first time, I had a reason to think about screening that patient because I actually do have an effective treatment that I may be able to offer that patient. So I think that all these years of research is really leading to a shift in terms of how we can start thinking about preventing and delaying type 1 diabetes in our patients.
Very exciting. Thank you so much. Our next panelist is Dr. Stephen Arnold, who's a professor of neurology at Harvard Medical School and director of the Alzheimer's Clinical and Translational Research Unit at Mass General Hospital. And the program that he's going to describe is Towards a Simple, Cost-Effective Blood Test for Alzheimer's Disease.
Number 11, toward a simple, cost-effective blood test for Alzheimer's disease.
Alzheimer's disease and other neurodegenerative conditions represent a major public health burden. By 2050, it is projected that some 13 million people in the U.S. will suffer from Alzheimer's disease, and the cost of care will approach $1 trillion. The first signs of neurodegeneration typically emerge in midlife, decades before the onset of dementia. In order to accelerate the development of effective treatments, researchers need a cheap, straightforward way to identify those who are at risk for Alzheimer's disease, but are not yet showing outward signs of the disease. Scientists are now working towards this goal. Their efforts involve identifying molecular biomarkers found in blood or other readily accessible biological fluids, which can be detected decades before the onset of symptoms and predict future disease risk. By translating these findings into a simple, accurate, cost-effective blood test, researchers can enable the diagnosis of neurodegenerative diseases many years before the onset of physical symptoms, when the course of the disease could potentially be halted or perhaps even reversed. Disease-modifying therapies are another key piece of this puzzle. They are essential for fully realizing the potential of diagnostic biomarkers of neurodegeneration. A variety of efforts are underway to develop novel therapies for Alzheimer's disease, as well as other neurodegenerative conditions, with some notable FDA approvals in the last year. In order to ensure health equity and to alleviate, not exacerbate, the societal burden of Alzheimer's disease, these therapies should be accessible to those who need them most.
Thank you, Dr. Arnold. Can you approximate for us the time to impact that is? When can I go and get a test to see if I'm at risk for this disease? And how's that going to change my life and the life of others?
Sure. Thanks for the question and the opportunity to speak with you. So, for a long time, 10, 15 years, we've had PET scans or spinal fluid testing that can accurately diagnose whether there's any of the amyloid plaques or tau tangles in the brain, the Alzheimer pathology. But what we've witnessed over the last few years is just tremendous advances in the ultra-sensitive reagents and the precision of certain technologies to be able to detect the tiny amounts of this amyloid or tau that are present in blood and plasma. And with a lot of research, the game has already changed for clinical trials, research, and we are poised now to change the game in clinical practice. The reason why this is so important and timely right now is that finally, as most of you know, we have a couple of, after decades of and extraordinary amounts of money spent in trying to develop disease-modifying treatments, we now have some medications that do look like they can actually modify the disease. And so recognizing it early will be able to promote the prevention. There are already blood tests on the market for and available for Alzheimer's disease, but one company, C2N, has a process, but it is a very sort of haute couture kind of assay requiring immunoprecipitation and mass spectrometry, and it just will not scale well. However, we now have these reagents and automated platforms that can, I think, will increase the efficiency with which we can measure these. And as the data accumulates in the next year or so, I expect that these blood tests for Alzheimer's disease will be ready and available for uptake at the LabCorps and Quests and the hospitals.
That's super exciting. Thank you so much. Our next panelist is Dr. Joan Miller, who's the Glendenning Professor of Ophthalmology at Harvard Medical School and the Chair of Ophthalmology at Mass Eye and Ear. And she's going to discuss a program of protecting retinal cells to preserve vision.
Number 10, protecting retinal cells to preserve vision.
When the specialized neurons of the retina degenerate and die, vision impairment and eventually blindness ensue. While the causes of retinal degeneration are varied, a common treatment strategy is in the works that could help the tens of millions of people in the U.S. with retinal disease. The idea is to provide protection and support that is targeted to retinal neurons, but agnostic to the initiating injury, thereby promoting their survival and preserving vision. Such neuroprotective strategies are now a major focus of therapeutic development efforts. One effort involves the development of an inhibitor against the FAS receptor. Signaling through the FAS receptor has been implicated in a variety of retinal diseases, including macular degeneration, diabetic retinopathy, glaucoma, and optic neuropathies. Clinical studies are underway evaluating the injection of a therapeutic solution containing the FAS inhibitor into the eyes of patients with different conditions. The results of Phase 1 studies in retinal detachment and age-related macular degeneration show promise, and further trials are now underway. Neuroprotective therapies for retinal disease are distinct from those that aim to restore vision in a targeted manner by replacing lost components, such as mutated genes or missing cells. Nevertheless, the potential of neuroprotective therapies is remarkable and has the advantage of being applicable across a range of disorders. Preserving vision is a top health priority for most adults who fear vision loss only slightly less than cancer, as it can trigger social isolation, loss of independence, and depression.
Dr. Miller, where do you see these technologies having the biggest therapeutic impact?
Thanks, Paul. I think neuroprotection has had to overcome a few hurdles due to some real struggles early on in developing treatments in the CNS. But I think, like we've learned in the development of gene therapy, the retina turns out to be a great place to develop these CNS therapies. And we're really excited about the promise with neuroprotection here. I think a big disruptor will be a treatment for the advanced form of age-related macular degeneration, for which we have very little to offer. And that affects about 40 million people worldwide. But beyond that, other retinal conditions, diabetic retinopathy and vascular disorders, which is another 100 million, and even glaucoma, which is over 70 million, will be a huge, again, treatment benefit for patients. And then lastly, while we're very excited about gene therapy for inherited retinal conditions, there is still progressive vision loss with those. And again, neuroprotection could be an adjunct there and make a huge difference.
Thank you so much. Our next presenter is Dr. Florian Fintelman, who is an associate professor of radiology at Harvard Medical School and a physician scientist at Mass General Hospital. And the program he'll discuss is an artificial intelligence tool predicting lung cancer risk in smokers and non-smokers.
Number 9, AI tool predicts lung cancer risk in smokers and non-smokers.
Lung cancer causes more cancer deaths among American adults than any other cancer. The reason is twofold. The disease is common, and once it has advanced, it's difficult to treat. That's why early detection efforts are focused on those believed to be at highest risk, patients with a history of cigarette smoking. Yet recently, a troubling rise in lung cancer among non-smokers has highlighted key gaps in current approaches. To help bridge these gaps, researchers have developed an artificial intelligence tool that can predict whether patients will develop lung cancer within 6 years. The AI-based tool uses low-dose CT scans of the chest to identify early signs of lung cancer. Current lung cancer screening recommendations for patients with a significant smoking history include a yearly low-dose CT scan. The new AI tool was developed using low-dose CT scans of patients from the US and Taiwan, including both smokers and non-smokers.
It can analyze a single patient scan and doesn't require additional clinical data or radiologist interpretations. In retrospective studies, the tool accurately predicted the future risk of lung cancer in patients regardless of smoking history.
This AI-based method, which was designed to be integrated at the point of care, could help close important gaps in lung cancer screening for both smokers and non-smokers. However, more work is needed to validate the tool, including a prospective clinical trial before it can be deployed in the clinic.
So Dr. Fintelman, this is working in the research setting now. What do you have to do to get this into the clinical practice so that everybody can benefit from this amazing advance?
Thank you for allowing me to talk about this collaborative project, which came out of a collaboration between the MIT group of Regina Barzilay and the MGH Cancer Center with Alicia Sequist at the helm. So the three of us, me from radiology, oncology, and engineering, set out to tackle this question. In terms of how to get this into the clinic, we're really thinking about it along 4 axes. The first one is we need to kick the tires of this some more. So this was developed using the National Lung Screening Trial data set, and that's 30,000 patients, and then we validated it on over 10,000 patients, both from MGH and from Taiwan, again, including smokers and non-smokers. So a huge effort has gone into it, but before we roll this out or make even efforts to roll this out, we need to make sure no inequities are baked into that model as is. I'm talking about racial inequities, I'm talking about sex differences because the NLSD cohort was 60% male. So manuscripts are in preparation showing that we don't perceive any of those inequities, but we need to finish the rigorous process. The second axis has to do with the clinical care paradigm. How are we going to integrate a risk prediction tool that doesn't tell us where the cancer is or what kind of cancer it is, just what the risk of cancer is into the care pathway? I see a clear use case in terms of giving patients the ability to skip potential annual screening, which is the current paradigm, but that needs to be evaluated prospectively, and that's where we're actively looking for funding to move this forward. The third paradigm, or the third axis really, is patient acceptance. So we have studies in preparation looking at patient acceptance of having an AI tool opine on their care. And lastly, the FDA regulatory process. We put that last because we really want to focus on 1, 2, and 3 and partner with stakeholders in that and then move it through the FDA.
Very exciting and definitely will save a lot of lives. Thank you so much. I'd now like to invite Lilit Garibian to the podium.
Thank you so much, Dr. Anderson. So our next panelist is going to be Dr. Stephanie Seminara. Actually, I'm sorry. I mixed up the order. David Ting. That's what I had, David Ting, but David is not in that order. Okay.
I'll just take it from here.
Okay, that's what I thought, and then I just, okay. Okay, I apologize. Our next one is number 8, Dr. David Ting, who's Associate Clinical Director for Innovation at Mass General Cancer Center and Associate Professor of Medicine at Harvard Medical School. And the technology he will be talking about is defining a new era of precision oncology.
Number 8, defining a new era of precision oncology.
A new class of bifunctional precision cancer therapies is gaining traction, in which one part of the drug is designed to zero in on tumor cells and the second part delivers a cancer-killing payload while limiting damage to healthy cells and tissues. One approach involves linking tumor-homing molecules to radionuclides, which use radiation to destroy tumor cells. A promising example is the recently approved targeted radionuclide therapy for advanced forms of prostate cancer, which is aimed at a protein on the surface of prostate cancer cells called PSMA. Part of what makes these therapies so powerful is the rise of companion diagnostics that allow clinicians to first visualize tumors that carry the target protein on their surfaces prior to treatment. By pairing diagnostic imaging with targeted therapy, an emerging area known as theranostics, clinicians can non-invasively see the tumors they intend to treat before they treat them and monitor treatment response. Another type of targeted therapy uses antibodies coupled to chemotherapy drugs. These therapies, known as antibody-drug conjugates, or ADCs, have evolved rapidly over the last several years, with the flagship case based on the well-known antibody against the HER2 protein on breast cancer cells. HER2-based ADCs have transformed the treatment of some forms of breast cancer. Now, a new generation of ADCs are under development and promise to replace conventional, systemically administered chemotherapies for the vast majority of cancers within the next decade, defining a new era of precision oncology.
Great. So, Dr. Ting, how do you think these innovations will evolve over the next several years?
Well, thank you so much, Lilith. And I'm excited to tell you that we had our first round of Precision Oncology 1.0 where we really looked for targeted mutations and developed drugs against those drivers in cancer. But those cancers are the vast minority of cancers that we see in the clinic. And I think the future is now where we have now developed these new antibody delivery vehicles that are homing on the cancer cells specifically, finding antigens on those tumor cells that we can deliver a payload. And so I think one of the first things that I look forward to in the future is really finding new targets on those tumor cells. And some of that may be coming from some of the antigens we know about, but some of them are hidden in the dark genome. Some of those are things that are only in cancers that we have yet to discover. And developing antibodies against those will deliver these types of radiation therapies and cytotoxic warheads to the tumor specifically. Part two is really, what about all of those therapies that we developed for a variety of different kinases or other things that failed because of side effects in patients? All of those therapies are now at play because we have a way of delivering those payloads to the tumors themselves. So I think this is an opportunity to look at some of these drugs that we had developed and unfortunately have failed in clinical trials that we could deploy into the clinic today in the near future. And probably the last is the way that we are treating cancers today, the difficult cancers like the cancers that I take care of, like pancreas cancer. We are now going after the cancer early. We're giving combination chemotherapy, radiation, and then surgery to get to cure. And this type of therapy could be an opportunity to give therapies for those cells that got away. And this is something we would give after all of those therapies as a potential way of getting us closer to cure.
Okay, great. Thank you so much. So our next panelist is Dr. Stephanie Seminara. She's the Chief of Reproductive and Endocrine Unit at Massachusetts General Hospital and Professor of Medicine at Harvard Medical School. She will speak about a novel non-hormonal treatment for menopause.
Number 7, a novel non-hormonal treatment for menopause.
During the transition to menopause, many women experience a range of symptoms, which can be extremely debilitating. These symptoms result from the declining levels of estrogen and other hormones. One of the most common symptoms is hot flashes, which are periods of intense warmth and sweating. They can be severe and significantly disrupt quality of life. Hot flashes can first emerge months to years before menopause and persist for over 10 years. Hormone therapy is the most effective current treatment. However, it is not an option for some women due to health concerns. Others choose to avoid it. Now, a novel drug could expand the treatment options for perimenopausal women. The drug was recently approved by the FDA after 3 clinical trials involving over 3,000 women. The results showed that the treatment, taken orally once a day for a year, can reduce the frequency and severity of hot flashes. The new non-hormonal drug works by blocking the signals that stimulate a key group of neurons in the brain that help control body temperature. Typically, these neurons are inhibited by estrogen, but with declining levels of the hormone, their activity is left unchecked. Research that helped unlock the biology of these neurons and their molecular signals has been critical to the development of the new drug, paving a path toward a safe and effective non-hormonal treatment for menopause symptoms that can improve women's health and quality of life.
Great. So Dr. Seminar, great work. Our question is, what does this innovation mean for patients? If you could tell us a little bit about that.
Sure. Actually, we can be the disruptive dozen, but we can't line up backwards and get our seats right. So I think what this means for patients is choice. Choice where there have been very few, or for some patients, no choice at all. And perhaps this drug actually represents a potential sea change in how we conceptualize the management of reproductive conditions. So taking a step back for a minute, 50% of the people on this planet will undergo menopause. 80% of women will have symptoms. And as the video said, those symptoms can last on average 7 to 9 years, sometimes over 10 years. The most common ones are vasomotor flushes and night sweats. And these symptoms can be severe, affecting sleep, quality of life, mood, concentration, and sexual well-being. The treatments that are out there can be effective. Hormone treatment is effective, but most women aren't offered it, don't want it, or have a contraindication to it. So there has been an unmet medical need for alternative treatments in this space. And the sort of development of this drug, fezolinetant, was based on new understandings of the pathomechanisms underlying vasomotor symptoms. In the brain, there's an ensemble of neurons called KNDy neurons that secrete kisspeptin, neurokinin B, and dynorphin. And in the setting of menopause, when estrogen levels go down, these KNDy neurons, which already play a marquee role in reproduction, hypertrophy, they hypersecrete neurokinin B. And that neurokinin B touches the thermoregulatory centers in the brain, sort of the brain's thermostat. That triggers heat dissipation, there's skin vasodilatation, and patients get hot flushes and sweating and chills. So the development of a neurokinin B receptor antagonist specifically speaks to that pathomechanism. Now, it's early days of this drug. It was just FDA approved, but as a non-hormonal therapy, I think this drug may sort of sidestep some of the stigma associated with traditional hormone therapies and may actually renew our interest in the development of other non-hormonal therapies for women and men with reproductive conditions worldwide.
Thank you so much, Dr. Seminara, for that answer. So we'll move on to Disruptive Dozen number 6. Our panelist is Dr. Roger Hajar. He's the director of Gene and Cell Therapy Institute at Massachusetts General Hospital, and he will speak about the first in-human gene editing therapy.
Number 6, the first in-human gene editing therapy.
Gene editing has been heralded as a breakthrough technology to treat a range of genetic diseases, and various experimental therapies are now under development. One approach uses a genome editing system known as CRISPR-Cas9 to make double-stranded cuts in the DNA and repair errors in the genetic code. There are 2 main methods for delivering gene editing therapies. Remove cells, such as blood cells, from the body, treat them with the therapy, and then add them back. Or infuse the gene editing therapy directly into the patient, either intravenously to reach internal organs for treating a range of conditions, or into the eye for treating vision disorders. This in vivo method uses viruses, lipid nanoparticles, or other molecular delivery vehicles to carry the gene editing therapy to its target destination. One of the first in vivo editing therapies is now in early-stage clinical trials, and, if proven safe and effective, could signify a landmark in the history of biopharmaceuticals. It targets a disease known as transthyretin amyloidosis, ATTR, which arises when a protein, called transthyretin, misfolds and forms abnormal clumps. These protein clumps build up and damage important tissues and organs, like the nerves and heart. The one-time therapy has been shown to reduce the levels of these protein clumps in the blood, a step that could spare precious tissues and halt disease progression. Other in vivo gene editing therapies are also under development and could dramatically improve disease treatment. These include inherited forms of blindness and various genetic conditions that affect the heart, liver, and lungs.
Great. So, Dr. Hajar, with the advent of new, more specific gene editors, how do you think this is going to change the landscape of gene editing?
So, gene editing, since its discovery, has really been transformative. And the promise of disease modification by gene editing is being realized right now. So as we saw, one of the applications is in amyloidosis, which is a really terrible disease. As a cardiologist, I've seen many patients die of amyloidosis-induced cardiomyopathies, and the natural history of it is quite terrible. Another application that we'll see very soon available for patients will be in sickle cell disease, and that was one of the examples where you take bone marrow cells out, modify them, and re-inject them. Now, in terms of the CRISPR therapeutics, which is the first generation of gene editors, it requires a break, a double-stranded break in the DNA, and even though that can have obviously therapeutic effects, it may have also side effects. A new entry in the gene editing toolbox is prime editing, and that is focused on editing one base at a time, and by doing so, you have obviously much more precision, so you're able to treat more specifically diseased cells or diseased organs where the genetic mutation is causing the disease. Now, prime editing, we will see more applications as we go forward. However, we still have to work on the efficiency of prime editing and also the delivery, because prime editors are even bigger than CRISPR editors. That requires novel types of lipid nanoparticles or splitting them in viral vectors such as AAV. But the promise is immense, and we're really looking forward to this next generation in editors.
Okay, thank you very much. So our next panelist is Dr. Vasila Kovacheva. She's the Director of Translational Clinical Research at Brigham and Women's Hospital and Assistant Professor at HMS. She will speak about harnessing the power of large language models to improve healthcare.
Number 5, harnessing the power of large language models to improve healthcare.
Artificial intelligence holds promise for automating and streamlining information processing tasks across major industries, including healthcare. Over the last several years, major advances in a form of artificial intelligence, known as large language models or LLMs, are stirring excitement. LLMs, such as GPT 3.5 and others, work by sifting through massive data sets to discern patterns and relationships among words, a process known as training. Once the models are sufficiently trained, they can perform a variety of language-based functions, including recognizing, summarizing, translating, generating, and predicting text. Although there is great interest in the use of LLMs in healthcare, these tools are not yet ready to be deployed in the clinic. Researchers are now exploring how to best customize LLMs for medical applications, In addition, a variety of ethical and regulatory issues must be resolved, including concerns about bias and which regulatory approval path these tools will follow. Once these concerns are addressed, LLMs could have a significant impact in medicine by streamlining and supporting the work of physicians. For example, LLMs could reduce physicians' administrative workload by looking up insurance billing codes, communicating with insurance companies, and entering notes in patients' electronic medical records. These tasks consume a significant amount of clinicians' time and contribute to the high rates of burnout among healthcare professionals. In the future, LLMs could also provide clinical decision support, which offers information and suggestions to doctors at the point of care. LLMs could help generate a list of potential diagnoses for a patient, as well as options for treatment for consideration.
So, Dr. Kovachev, where do you see these large language models having the greatest impact in our healthcare?
Thank you, Dr. Garabedian, and thank you for the invitation. It is a great honor to be part of this panel. I think that probably the biggest impact that large language models will have in healthcare is when they're implemented in patient care. And naturally, this is a long road in front of us, and we're just making our first strides today. And as we are looking to translate this technology into patient care, we need to ensure that it is properly tested, supervised, and adequate guardrails are in place. In my lab, we're developing several use cases of these large language models. For example, for quality improvement projects, they can help with data analysis and visualization. They can notify if deviations from the current practice are noticed, and also suggest the best corrective action. In research, we leverage large language models to phenotype and subtype patients rapidly and very precisely. For example, in hemorrhage, these models can help us determine the etiology, the best treatment, and also the outcomes. As a result of that, this technology can be used to personalize diagnosis and treatment. In addition to that, longitudinally, these models can help with disease surveillance and enforce the best practices for disease management. And of course, we have to ensure that we do everything possible to mitigate bias so that the models work in an equitable way for all patients. These are just a few examples. I think that as this technology becomes more mature, we will see the implementation of large language models at every stage of healthcare delivery, with the prospect to improve the health outcomes for all individuals.
Okay, great answer. Thank you so much. And I will invite Dr. Rudy Tanzi now to introduce the rest of the panelists.
Okay, I hope you're all ready for your final four. And it's been exciting so far, such a great set of disruptors this year. So our next panelist is Dr. James Berry, who is the director of the ALS Clinic, chief of the Division of ALS and Motor Neuron Diseases at Mass General. And Dr. Berry's topic is new therapies for ALS.
Number 4, new therapies for ALS.
Amyotrophic lateral sclerosis, or ALS, is a devastating disease involving motor neurons in the brain and spinal cord. These neurons send signals from the brain to muscles, coordinating the movements required to walk, talk, eat, and breathe. In ALS, motor neurons degenerate and die, leaving patients paralyzed. Many patients do not survive beyond a few years after diagnosis. Recently, 2 new treatments were approved for ALS, bringing the total number of approved drugs to just 7. One of the new treatments involves a pair of drugs that work together to prevent neurons from dying. The 2 drugs, which were originally developed for other disease indications, are now being repurposed as a novel drug combination for ALS.
The other newly approved treatment is a gene-based therapy designed for patients with a genetic form of ALS. These patients, which account for about 2% of all patients with the disease, carry mutations in a gene called SOD1. The new gene-based treatment uses short strings of nucleic acid targeted to the SOD1 gene to reduce its activity. In addition to offering a much-needed treatment for an intractable disease, this new genetic therapy paves the way for a similar therapeutic approach for other genetic forms of ALS caused by mutations in different genes. The clinical trials for the new SOD1 gene therapy were also designed in a unique way, relying on a surrogate endpoint instead of clinical outcomes. The success of that strategy will hopefully catalyze further therapeutic development for ALS and other neurodegenerative diseases that urgently need new treatments.
Dr. Berry, this has been a really exciting year for ALS, and you've been at the center of these treatments and developments. How do you see the next several years of this rapidly evolving landscape for treating ALS?
Yeah, thanks for having me. I think this is a really incredibly exciting time for ALS drug development, and as evidenced by the fact that in the last 12 months we've had really 3 new therapies that were approved by the FDA after having a long time where we didn't have anything like that happening in ALS. And that's really just the tip of the spear. And the reason for that is that there are big advancements that are behind the development of those therapies and behind the development of therapies that are coming. The first one is that we understand the biology and the genetics of the disease better than we ever have before, and that gives us targets that are more likely to give us successful drug therapies for ALS. The second one, as you heard, is that we understand biomarkers of the disease much better, and we can actually apply those to clinical trials in a way that allows us to shorten those trials and bring us a more certainty about the biological effect of the drugs that we're treating. I think a third one is that, as you've heard in this panel, we have really powerful new therapeutic strategies coming to ALS and in trials, things like gene therapies and RNA therapies, antisense oligonucleotides, and really targeted, powerful small molecule therapies. And that's, I think, again, building on all of the knowledge we have about the disease, really increasing our chances of success. And finally, with all these advances coming, we really need new approaches to clinical trials so that we can work quickly to test new therapies, to pick out the ones that are going to be most successful. And so we have new approaches like the Healy ALS platform trial that allows us to test multiple therapies at the same time, not against each other, but against placebo. But do that in an efficient way so that we can get through all of these exciting therapies as rapidly as possible. And even applying digital biomarkers so that we get quantitative readouts and get to sort of an understanding of which of these drugs are having a clinical benefit more rapidly.
Thank you, Dr. Berry. Excellent. And our next topic is a very exciting area of building the next generation of mRNA vaccines, and our panelist is Dr. Lindsay Baden.
Number 3, building the next generation of mRNA vaccines.
mRNA technology was pivotal in the development of COVID-19 vaccines. The remarkable success of these mRNA-based vaccines, which proved safe and effective in millions of people worldwide, has thrust the technology into the limelight and propelled its wider application to vaccine development. mRNA vaccines offer several advantages over traditional vaccines, which are often protein-based. The technology can be used to produce vaccines quickly and cheaply. It also enables the rapid modification of existing vaccines as new viral variants emerge, as they did during the COVID-19 pandemic, and the creation of multivariant vaccines that target multiple variants or even multiple pathogens at once. In addition, mRNA vaccines can be readily scaled up, making global distribution a possibility. Prior to the COVID-19 pandemic, several mRNA vaccines were already in the works, including personalized cancer vaccines and a vaccine against the Zika virus. Now, scientists are also leveraging mRNA to develop vaccines against a number of respiratory viruses, including a combined vaccine against the big 3: COVID-19, flu, and RSV. There are also efforts underway to develop vaccines against pathogens that have thus far proven difficult to target using standard vaccine approaches, such as the microbes that cause malaria and TB, herpes simplex virus, Epstein-Barr virus, and HIV.
Dr. Baden is the Vice President of Clinical Research at Brigham. And Dr. Baden, question for you is, we've seen really mRNA vaccines during COVID as a godsend for the population, and it's only just the beginning. Where do you think mRNA technology will have its greatest therapeutic benefit going forward in the future?
Thank you for highlighting, I think, a tremendous advance over the last several years. I think of mRNA vaccines or mRNA delivery somewhat like PCR. PCR transformed how we diagnose infections and many diseases. I think mRNA is a delivery platform that can deliver an immunogen, an antigen to the immune system, allows cellular processes to make the protein, fold it conformationally correct, and display it. Therefore, it is a platform that can allow us to deliver immunogen, antigen, to the immune system conformationally appropriate rapidly. What we can do with this technology, we're still learning. What we've done with COVID, as was mentioned, I think is remarkable. In fact, 11 months ago, the FDA met to discuss what to do about Omicron and decided that we should have a vaccine to Omicron from the ancestral strain. About 10 months ago, it was authorized and delivered to the community and hopefully to all of us in this room. In fact, tomorrow, the FDA is meeting yet again, the VRBPAC meeting, to discuss what to do about the next iteration of the COVID vaccine and sequence. And it wouldn't surprise me if by Labor Day this year, another formulation is in the CVS, Walgreens clinics for all of us to receive. That shows us the potential speed, scalability, scientific iteration that is possible with this technology. Currently, our flu vaccine, for example, we commit to the antigen, to the insert, months ago for the season that will start in a few months. Matching of that to the circulating antigen is tricky and often suboptimal. So I think this technology brings speed and allows us to adapt to the most relevant pathogen and can be used for any pathogen that we need an immune response, be it CMV, HSV, EBV, Marburg, Ebola, all sorts of viruses of concern, as well as cancer antigens. We need to know the target, and then we can ask the immune system to do its work.
Thank you, Dr. Baden. Very exciting. We look forward to the future. So we are down to our final two, and our next panelist is Dr. Shadi Al-Salibi, who is an assistant professor of pediatrics at Mass General and Harvard Medical School, and the topic is, along the same lines, RSV vaccine approaches in the clinic.
Number 2, RSV vaccine approaches the clinic.
Respiratory syncytial virus, or RSV, typically causes mild or no illness. But in vulnerable populations, including the very young and the elderly, it can be a serious threat. Last fall and winter, the U.S. endured a particularly severe surge of RSV, a situation made worse in part by the lack of an effective vaccine. Now, after several decades of work, a vaccine is within reach. One RSV vaccine was just approved by the FDA for use in older adults, and another is under agency review. 2 others are in late-stage trials, and several more are being developed. In the 1960s, scientists first embarked on an effort to develop the first RSV vaccine, but it hit a tragic roadblock. Some infants who received the vaccine and were later infected with RSV became severely ill. 2 died. Researchers spent more than 30 years figuring out why, while also dissecting the biology of RSV and the molecular basis of an effective immune response. A particularly crucial innovation involves a key protein on the surface of the virus, known as the F protein. It changes shape when the virus fuses with a cell during infection. The immune system can better detect the F protein in its initial, pre-fusion state, which results in higher levels of the antibodies needed to protect against infection. Scientists devised a way to lock the protein in its initial configuration, which propelled vaccine development efforts, not only for RSV, but also remarkably for other viruses, including SARS-CoV-2.
Dr. El-Salibi, it's been, RSV has affected so many folks, young and old, and the most vulnerable in our population, and this is so exciting. What can you tell us about the timeline, and what will be the impact of the RSV vaccine as it approaches the clinic?
Thank you for inviting me. This is enormous, huge, gargantuan. I can, keep going on and on and on. I think, since the debacle of the 1960s, like you just saw, this is the single most impactful intervention that really has hit, the RSV preventive world. I think to put things in perspective for everyone here in the room, it would be important to think about the burden of the disease per se. Like millions, like with an S, of children every year get the virus. By the age of 3, every small child by the age of 3 will have developed some kind of a clinically symptomatic illness with RSV. This is enormous. Only in the US, just in the US alone, 2 million kids will show up every year to their pediatrician's office with RSV disease. 5 to 10% of those will end up hospitalized, and then also 5 to 10% of those who are hospitalized will end up into the ICU. And if you think about the worldwide impact of RSV, 1 in every 25 child, or infant rather, under the age of 6 months is going to end up dying because of RSV. So, those researches that have been made recently are enormous, and they're going to impact this burden of disease in a major way. Unfortunately, it's not going to impact the acquisition of the disease, but the vaccine efficacy in preventing lower respiratory tract infection in the first 90 days to a first 6 months of life is about 80% to 70%. This is enormous. I see this being, a vaccine in the next few months. Hopefully, the maternal vaccine from Pfizer. This is, the first, leading in the context of which one is going to get approved first. This one is probably going to make it to market in the next few months. Hopefully, in the coming seasons, we will see this on every child's immunization schedule. And to be honest, I feel this should be like number 1 here. Sorry, Jerry.
It was very tight. Well, thank you, Dr. El-Salibi. It's truly exciting, and thank you for that update. And so now it is time for, we have a drum roll, Chris? No. This year's, as was voted, the top innovation in the 2023 Disruptive Dozen. And our panelist is Dr. Jerry Doherty, who's Surgeon-in-Chief at Brigham and Women's and a Moseley Professor of Surgery. And the topic is a new type 2 diabetes drug shows promise in obesity.
Number 1, new type 2 diabetes drugs show promise in obesity.
A new class of drugs has emerged that mimic GLP-1, a hormone that curbs hunger. These drugs, which were first approved for type 2 diabetes, can have remarkable effects on weight loss. In clinical trials of one GLP agonist, over half of the patients receiving the drug lost more than 15% of their starting weight. A next-generation drug is now under development, which mimics both GLP-1 and a second hormone involved in insulin secretion. It can yield even greater weight reductions. GLP-1 agonists can induce significant weight loss, but they must be injected and cost over $13,000 annually. Some people experience significant side effects, including nausea and vomiting. Moreover, patients must continue taking the drugs or risk gaining back the lost pounds. Obesity has become a global problem. According to the World Health Organization, 13% of adults worldwide are obese, a figure that has almost tripled in the last 50 years. While research suggests that obesity is linked to and can exacerbate a wide range of diseases, including heart disease, diabetes, and cancer, there have been few ways for patients who need to lose weight to do so safely and effectively. Although bariatric surgery is the gold standard treatment, it is invasive, and the majority of patients for whom surgery is indicated do not have it done. The new GLP-1 agonists are poised to fundamentally change that treatment landscape. But our society must also grapple with questions that surround the uncertainties associated with long-term use, equity, access, and the potential harms of overemphasizing weight loss.
Dr. Doherty, obviously obesity is a big problem in this country worldwide and a risk factor for type 2 diabetes, so it's kind of appropriate that the same drug can be used. Tell us, what will be the impact? How widespread do you think we will see the use of this type of drug for obesity, and what's the future in terms of similar drugs that might even be more affordable along the way?
Thank you, Rudy. I appreciate being #1 this year. Surgery is an incredibly effective treatment for obesity and diabetes. We do some rearrangements of the upper GI tract. It creates immediate neurohormonal changes for the patient that impact not only nutrient metabolism, but also the sensations of satiety. Before patients leave the hospital, many of them have had resolution of their diabetes. And they haven't lost a pound yet, so it's not just weight loss that is impacted here. Those effects are also durable. More than 90% of patients have durable resolution of their diabetes and sleep apnea. More than 75% have resolution of hyperlipidemia and hypertension. There's a 50% decrease in myocardial infarctions. And most amazingly, at 5 years, the all-cause mortality goes down by 60% in people who've had bariatric surgery compared to those who haven't. The problem is that people don't want surgery. So only about 1% of the people for whom surgery is indicated in the United States actually have the bariatric procedure each year. And so 99% of patients are not treated by our most effective strategy. The GLP-1 agonists mimic some of those neurohormonal effects that are created by the operation, and may be more acceptable to patients because they can get those effects without having a procedure. They don't have the fear of the operation that they would have with bariatric surgery. If we could move the needle from 1% of the patients being treated with an effective therapy to 10%, we could treat 2.5 million of the obese and complicated patients in the United States. At the end of 5 years, we would have prevented 100,000 deaths, which I think is rather amazing, and it really is a disruption to those patients' health trajectory, and I hope we'll get there.
Well, thank you, Dr. Doherty, for that very insightful answer and having the #1 seat in our Disruptive Dozen. And so that concludes the Disruptive Dozen. I'd like to congratulate the World Medical Innovation Forum for just doing such a great job again at putting together another fantastic Disruptive Dozen, and especially I'd like to congratulate all our amazing innovators on this year's Disruptive Dozen panel. Thank you very much.